excited to introduce Bob Hyzy, who's going to be speaking on non-invasive respiratory support. I'll let him introduce himself and highlight anything in an informal way, but he's a professor of medicine here and a clinical trialist and an expert in ARDS, although be speaking today about non-invasive respiratory support. And he also dabbles in global health and some work around the world as well. But thanks, Bob, for giving the conference.
Okay, thank you, Jake. Yes, I thought I'd give this lecture today to demonstrate I can lecture on something besides ARDS, but the impetus of this lecture rests in two things. One is that along with some of our faculty, I'm telling our fellow applicants now, I write several, I think 14 topic cards for up to date about mechanical ventilation, including these issues. And secondly, I'm involved with American College of Chest Physicians on a guideline. I'm chairing a guideline we're developing on non-invasive respiratory support. We've got 8 PICO questions, and we're in the librarian phase, if you will, which is the data research phase. But certainly,
Bob, there must have been somebody very insightful on the guidelines oversight committee to make sure that that project got approved at Chest. Just throwing that out there.
So thanks for the interruption, Doug. I guess that beer I was supposed to buy you, I didn't make good at.
Quite all right. Put it on my tab.
Okay. So anyway, yeah. So we're going to have a guideline, and hopefully it'll be out, I would say, fourth quarter next year. All right. So invasive mechanical ventilation, we all know and love it in the ICU, but I think we can all agree if you can avoid a tube, that's worth it because of all the various things that can happen, like ventilator-associated pneumonia, barotrauma, lung injury, laryngeal complications, diaphragmatic weakness from prolonged weaning, nosocomial sinusitis, hemodynamic embarrassment, oxygen toxicity, stress ulcers, increasing cranial pressure. So it's certainly a good thing. And so our lecture today, we're going to talk about a couple of things. One is conventional, I call it NIV, non-invasive ventilation. It's been NIPPV, non-invasive positive pressure ventilation. There's a couple of abbreviations people sometimes use. Heated high flow, the newer kid on the block, and then the added twist of helmet ventilation, which is a form of non-invasive ventilation using a distinct interface of a helmet. Okay, so let's talk about non-invasive ventilation. This is a form of partial ventilatory support. Of course, when you stick a tube in someone's trachea, you blow up the cuff and you're trying to provide full support. The diaphragm does some work, but you cannot accomplish as much diaphragmatic rest, if you will, with partial support. You see here a full face mask. Usually the interface is different. You know, when you have someone as an outpatient who has sleep apnea, sometimes you get away with things like nasal prongs. You really don't use that in the acute care setting. Patients are short of breath. They tend to be mouth breathers when they're short of breath. So at the very least, a full face mask, if not something bigger, is employed. The indications for non-invasive ventilation, the gold standards, are acute on chronic hypercapnic COPD exacerbations and cardiogenic pulmonary edema. These are the things that really put it on the map. I'm going to go through that a little bit with you with some of the historic detail, just for those who may not know it. You know, the question about a COPD patient who's not hypercapnic, the literature is iffy. It doesn't really pertain as much to that population. You're talking about someone who's chronically running PCO 250 that goes to 60, that's exacerbating is the kind of person you're interested in. In terms of cardiogenic pulmonary edema, you're not talking about cardiogenic shock or going off the cath lab. You're talking about just an exacerbation of volume overload, if you will. There's a couple other issues. Immunocompromised patients have been looked at separately and found not necessarily to benefit, but we still do it. We'll talk about post-extubation issues, and you can use a palliative care. Obviously, goals of care need to be carefully considered. You can become a failure to wean from non-invasive ventilation, just as you might with invasive mechanical ventilation. So you have to go in with that knowledge in hand. All right, so contraindications of non-invasive ventilation more or less pertain to airway issues. If you're post-arrest, if you need to be emergency intubated, if you're encephalopathic, you're vomiting blood or hemodynamically unstable, you have facial trauma, upper air obstruction, can't protect your airway, you're drowning in secretions, high risk for aspiration because you may end up blowing air into the stomach as well, and morbidly obese patients. I put in gray ARDS patients, more on that later. And some of these things are absolute in contraindications. Morbid obesity is more of a relative one. There are series that show you can use this. and as well as patients who might have some degree of encephalopathy, particularly if that's CO2 narcosis. When you use it in those two contexts, you better be careful. In other words, if you have acute or chronic COPD exacerbation with a little bit of CO2 narcosis, and you're able to blow them down, if you will, with a face mask to wake them up and put the mask on, you might just get away with avoiding a tube. But obviously, you don't want to be dilly-dallying if they need emergent intubation. Same thing, more of obesity. One of the keys for a non-invasive ventilation is to know when you're not succeeding. And so the last thing you want to do is take a morbidly obese patient who you can't see anything but soft palate when you stick a laryngoscope in, and wait until they're breathing down before you intubate them. All right, so just the advantages are genuine. The literature has shown that an acute and chronic hypercapnic COPD number need to keep a tube out of 3, and the number you need to treat to save a life with COPD is 11. That's a pretty potent intervention when you think about it. Now, the converse way of looking at that is that maybe 2 patients didn't require non-invasive ventilation, might have been just fine, but you don't know who the 2 is and who the 1 is. But it's fairly potent intervention. Number need to treat 3 and 11 for survival. I put over here to the right, just for historic purposes, Umberto Midori, when he's in Norwalk, Connecticut, was the first person to take this modality. We actually used to have a little BiPAP machine, not an ICU ventilator, and put it on some hypercapnic COPD patients in the ICU there in Connecticut. And just to show you that diagram from that article in 1989, and just to tell you, it's not been that long in the history of intensive care medicine, which itself isn't beyond 50 years, but that we've been doing this kind of thing in the ICU. It used to be, I mean, in Midori, when you first started putting masks on people who otherwise you would intubate, people thought that was kind of a dangerous thing to do, but it can be dangerous if you're not using your head, but you can get away with keeping a tube out, which I say is worthwhile. Okay. Now, what about asthma? We got ACOS, there's overlap syndrome, what have you. And the basic bottom line is it's not been studied in any rigorous prospective randomized fashion. Now, certainly the COPD studies are not blinded. It's pretty clear who's got the mask on and who doesn't, but we don't have anything even analogous to asthma. And we do have our large database analyses that suggest that it might particularly work, but those that fail are more likely to have more than just asthma, things such as pneumonia or severe sepsis to go along with it. If you think about asthma on the vent, it used to have a high mortality and invasive ventilation, because if you hyperventilate the lungs and don't allow them to empty, you might blow out the lungs. And later on, I'll show you some data that suggests that sometimes you can deliver some pretty significant tidal volumes with non-invasive ventilation. Well, anyway, the most recent guidelines, which I'll go into a little more detail later, don't make a recommendation on the use of asthma because there's really not good evidence. So let's talk about cardiogenic pulmonary edema use of non-invasive ventilation. And I'm fond of saying in the ICU that positive pressure ventilation, be it with an ET tube or a mask, is not a state of nature, right? We usually use negative pressure ventilation, suck air into our lungs. When you start pushing air into people's lungs, hemodynamic changes occur, which include, of course, you're probably familiar with decreased venous return, but that would also increase RV afterload. But on the left side of the heart, you'll decrease LV afterload as well as preload, and that can actually have a salutary effect. So not only in the setting of cardiogenic pulmonary edema are you redistributing lung water and improving oxygenation, you also can improve with hemodynamics. So here's a historic footnote here to the right. This is a Blue Journal, before we even called it the Blue Journal, article from 1992. Patients went to the cath lab who had high wedges versus low wedges, and they had CPAP applied. And you can see that if you're in failure, the high wedge, your cardiac output goes up, and if you're kind of already tuned, or it goes down. So you can have a beneficial effect on the failing ventricle. So the salutary effect of CPAP or BiPAP in cardiogenic edema is not only redistributing lung water, it's hemodynamics by virtue of the changes in the chest. And the original paper, even before Midori, you see here from 1991, CPAP in cardiogenic pulmonary edema decreased significantly the requirement for intubation over those that received just a simple oxygen mask. Now, there was no mortality benefit, but that was what put CPAP on the map in the ICU for cardiogenic edema. We do have some more data on this. The biggest study was called C3PO, was in New England Journal 2008, which did not really have mortality or intubation benefit. But when you look at meta-analyses, you do see a benefit of, again, not mortality like with COPD, but at least decreased rate of intubation. So some of the technical aspects of non-invasive ventilation are, in the old days, we were using just a respironics BiPAP machine. Well, we have ICU ventilators that adapt to the task. Usually you start with bi-level, which is a inspiratory puff of air like a pressure support, and expiratory wind in your face like CPAP or PEEP. You start low and work up. As I said, full face masks usually are in play here. You have to worry a little bit about the risk of aspiration. And the most important thing really is you got to know when it's not working. And most studies would say within an hour or two, you know, if you're still tachypneic and not drawing good volumes and your sats are not improved, you should just admit it's not working and move on and intubate the patient and not put the patient at risk. Now, we do have the newer kit on the adult block. It was in the pediatric world before it, maybe over the last 10 years, it was used in adult ICUs. And you see our guy over here, what a happy camper he is with his heated high flow. And heated high flow is more than just an oxygen, way to deliver oxygen. It, because of the high flows, gives you a CPAP effect. It's not a ventilator, obviously. It's not pushing air in your lungs like PSV, but it is giving you CPAP. And the higher the flow, and we're usually in the 40, 50, 60 liter per minute range, the more CPAP effect. And this also has a benefit of a precise FiO2 compared to, say, nasal cannulas that are not high flow, or face masks with little discs that are supposed to open and close, because it washes out dead space. So this is a newer kit on the block. And when you look at it physiologically, it's not the same, as I said, as an oxygen mask. Because of that CPAP effect, you can decrease work of breathing. You can decrease pressure time product and change in esophageal pressure, both of which are surrogates for work of breathing. And by the way, you recruit lung. Just like with PEEP on someone on a vent, you can increase end expiratory lung volume without altering tidal volume. So you could argue for a patient with hypoxemic respiratory failure who is not on the ventilator, i.e. what we're going to go on and tell you by our new definition, ARDS, on heated high flow, you can open the lung, if you will, without over-distending it. Now, we do have this modality. We're using it. How do you know when someone's failing that? Well, rapid shallow breathing is hallmark respiratory failure, regardless, and you don't have to whip out your little calculator to calculate the ROX index, but it's been put forth as a heuristic. Certainly when the pandemic hit, we had a lot of heated high flow on the floor, and we had our hospitalists using this. You see some isoplus here. What are you really saying with this ROX index? It's sat over FiO2 divided by respiratory rate, which is to say, we used to talk in the COVID pandemic about the happy hypoxics, right? The happy hypoxemics. They're on like 80% heated high flow, but they're breathing 12. And you're really going to say, well, because you're on a high FiO2, I'm going to go put you on invasive mechanical ventilation. The answer is no. Now, in this case, the higher the number, the better. If you want a number to stick in your head, think about 5. In fact, a number 5 at 6 hours is the best predictor of success. On the other hand, just as with non-invasive ventilation, I suggest to you that if you have to wait, that you shouldn't wait 6 hours when someone's obviously and miserably failing the modality who needs to be intubated. So this is a kind of a semi-useful thing. If nothing's perfect, but it can give you a little reality check as to how the patients do. But it's not rocket science, right? How fast are you breathing, and what's your FiO2 requirement and saturation? Those are the 3 simple variables combined into one number. And again, the higher, the better; the lower, the worse. Now,
Bob, there's a question in the chat from Davey about does the heated high flow CPAP effect depend if the patient has their mouth open or closed?
Not really, because you are washing it out. No, as opposed to face masks, those flows, you're going to get the pressure. Yeah, you know what? I can't see the chat, so if that popped up, I didn't see it. So Jake, if someone does,
I'll keep an eye.
Usually it comes on your screen. It didn't come on my screen. So, all right. Well, anyway, so as I said, this has been studied a lot. It was kind of interesting. The implementation was already ongoing prior to the pandemic, but we used the heck out of this stuff. And by the way, early on, I was very, definitely afraid about aerosol dispersion of coronavirus with heated high flow, which was largely found to not be true, and then we used the heck out of the stuff that I think probably kept a lot of people off the vent. But here you can see a series from JAMA a couple of years ago in COVID. The upper graph showing you how the rate of intubation was decreased and clinical recovery perhaps enhanced. Just as with non-invasive, when you cherry pick the I worry about this because these immunocompromised subgroups have been isolated both with non-invasive and immunocompromised, and these modalities don't seem to work as well. And I don't know. Let's put it this way: we use them anyway. We just ignore that because what do you want to do? Stick a tube in them? And you've got plenty of anecdotes saying you seem to keep tubes out. But just for the sake of argument and completeness, that this has also been isolated and not found. The benefit, overall, probably no mortality benefit, decreased risk of the need for invasive mechanical ventilation. You can argue this two ways, of course, right? I mean, anytime you have a surrogate endpoint, mortality is the ultimate endpoint. But when you don't see a mortality benefit, you wonder, and we can all agree keeping a tube out's a good thing. Now, is it keeping a tube out's a good thing and mortality is the same because it just doesn't matter, or because maybe the data set, as large as it might be, is not significant enough to tease out that mortality benefit? It's just like ventilator-free days, another kind of surrogate for mortality that you'd like to think things pull in the same direction. But the signal has been fairly clear about lack of mortality benefit. All right, so now we got these two modalities. Let me back up 1 second. And we're not going to argue about the gold standards of non-invasive ventilation. We're not going to argue about cardiogenic edema. We're not going to argue about acute and chronic hypercapnic COPD. But when it comes to having these modalities, we know that heat high flow can oxygenate hypoxemic respiratory failure. What about comparing the two? Thank you for asking, because a very important trial called Florali was done 2015. And this was a comparison of just a regular oxygen mask versus non-invasive ventilation versus heated high flow in a population that excluded those gold standards for non-invasive, i.e. CHF or hypercapnic patients, and also excluded severe neutropenic patients. The primary endpoint was intubation by day 20, and that was not achieved. However, post-hoc analysis showed that the sicker hypoxemics, i.e. PDEF ratio under 200, had a decreased rate of intubation. So that's kind of interesting, right? You say more hypoxemic patients seem to do better without that PSV component of non-invasive ventilation, but merely just the CPAP component, which is the other part of the non-invasive ventilation that you deliver. And surprise of surprise was a worse mortality in non-invasive ventilation compared to high flow in the high flow population. There are more ventilator-free days as well, obviously, because if you mix in those patients that stay off the vent. So that came as quite a surprise, and certainly is food for thought. Now, non-invasive ventilation is a pain in the butt. If you're short of breath, sticking a mask on someone can be challenging. We'll talk more about the helmet and challenge in just a minute, but heat high flow is pretty easy to implement. So heat high flow has certainly, with hypoxemic respiratory, taken the world by storm. Now, this Berlin criteria, and let me digress because, of course, I can't get through 40 minutes without talking about ARDS, because I mentioned to you that we use the heck out of this to keep people off the vent in COVID who had severe hypoxemia and bilateral alveolar infiltrates, which I assume you'll agree with me, were not due to atelectasis fluid or collapse, right? They had something you would probably call ARDS, and yet Berlin criteria from 2012 said, yeah, he either had to be on the event or non-invasive ventilation. Well, clearly those people had ARDS, so we've just changed the definition. Here it is. And this is now more abrasive, right? It includes heated high flow of at least 30. And the PDEF is pretty, I think, generous, under 300. We used to call that acute lung injury in ARDS with a PDEF less than 200. Same old story here with bilateral infiltrates. This isn't lobar pneumonia, and you can't be due to using your judgment, heart failure, what have you. But the point of the matter is, heat high flow does now qualify as ARDS, which is just only logical. But it didn't in 2012 when Berlin came out. It was not in widespread use in the adult population. Now I'm kind of crabby about this because I have a concern, and that is this: that a PDAF ratio to 300 is really generous. And here's some data that demonstrate that when you go from heated high flow to either non-invasive or invasive mechanical ventilation, your PDAF ratio, I mean, needless to say with invasive, but with non-invasive improves, right? So the notion of having a PDAF under 300 and is a patient with heated high flow with a PDAF ratio of 250 as sick as someone with 250 on non-invasive, let alone invasive mechanical ventilation? I doubt it. So whereas I certainly was in favor of having heated high flow patients qualify as ARDS, I'm a little worried that we may have gotten a little too sensitive and less specific. We do have the APS consortium, our new little wrinkle here to try to hopefully understand subphenotypes, but I worry that by the generosity of these criteria, we've gone a little bit too far in the sensitivity end and not quite in the specificity end. So let's talk about ARDS though, because in Florelli, remember I said Florelli, non-invasive ventilation had a higher mortality, which came as a surprise, but then maybe not so much a surprise. There had been a parallel literature to suggest that non-invasive ventilation give you pretty high tidal volumes. Remember, tidal volumes bad in invasive mechanical ventilation in ARDS. That's why we give lung protective ventilation, a plateau under 30, driving pressure under 15. Tidal volumes, ideal body weight 6 or lower often. But you can see these non-invasive does generate. So it was a speculation was maybe that this was the case in Florelli, that you're puffing, blowing these people up a little too big, and maybe as I showed you earlier, increasing N-expiratory lung volume with a CPAP effect of heated high flow is superior because it doesn't increase tidal volume. And in fact, we have another signal that suggested this might also be bad. There was a large international database called LungSafe. It was in JAMA, but another bit of data analysis suggested that ARDS patients with a PDAF under 150 who were treated with non-invasive ventilation had higher mortality. So another signal suggests that maybe non-invasive ventilation isn't the best thing to do. Now, is it the tidal volumes or is it they're working too hard? Again, I'm going to digress briefly because I think this is apropos of the conversation as it relates to heated high flow versus non-invasive. But right along the same time all this stuff was happening, and prior to COVID, so the two concerns were large tidal volumes with non-invasive. But the other thing was, are you working too hard? You're not relieving the work of breathing enough. If you're sucking air, can you hurt the lung? And that's called PSILI, patient self-inflicted lung injury. And the idea here is that by sucking air and vigorously, so do you just as bad as being on the vent pushing 8, 10, 12 cc's per kilo and worse lung injury. We call that PSILI. So a lot of people on board for this. It remains speculative, but this concept had emerged in the literature just at the time that COVID was happening, and Gatnoni and John Marini, two really well-known and well-regarded vent people, if you will, lung injury people, published this in JAMA, back in the early days of the pandemic when everyone, kind of things were crazy and unfolding and maybe not all evidence-based, but they said, hey, if you're working hard, don't bother with these respiratory support devices, just tube them, right? Avoid PSILI. The idea was that, if you're working hard, you may just make the lung injury worse. But I just want to emphasize to you that we don't know the answer to this. In fact, there are no clinical studies that demonstrate a ventilator strategy to limit PSILI improves outcome. I'm not saying that sucking air with large inspiratory volumes is a good thing, but at the very least, you should have esophageal pressure monitoring, which, and by the way, if you're on non-invasive ventilation or heated high flow without invasive ventilation, is not terribly appealing. So is non-invasive ventilation not for ARDS due to large tidal volumes or maybe inability to, with the ventilator synchrony and such? We don't know, but we do have one contrarian point of view that suggests that maybe it's a good thing after all, and that is the series that came out, again, pre-pandemic, Bhakti Patel, JP Kress, single center RCT done, University of Chicago, with I think, 80 some odd patients using a helmet. So instead of a face mask, they put a helmet. I showed you a picture of that earlier. It looks like a deep sea diver, only it's very distensible and plastic. And if you ask me what are the tidal volumes delivered by a helmet, the answer is I don't know, because the thing's just blowing up and down all the time. And we don't really know, but they found a mortality benefit with that. And as they said, places like Lombardy and Italy use the heck out of the helmet. And you can imagine that compared to the risk of dispersion of virus with heated high flow, the helmet obviated that. So here's a picture of Lombardy in March, and you can see all the helmets lined up and down. And they were on sale, man. There was a fire sale. People across the country were snapping these things up. We kind of stuck with heated high flow. But when you compare heated high flow to the helmet, it is true that non-invasive ventilation had with helmet had better oxygenation, lower respiratory rate, less dyspnea, but that pressure swing thing, that P-silly thing, was about the same. Transpulmonary pressure and comfort actually were about the same. So, so what about a head-to-head comparison? This is what's called a network meta-analysis, and this gets tricky, right? It's a syllogism. So a network meta-analysis is if A equals B and B equals C, A equals C. So here is the JAMA 2020 with the literature that was extant at that time, comparisons of mortality with comparing, say, face mask to standard oxygen, all these comparisons, okay, and then intubation. But we also have, via network meta-analysis, because what you'd really like to know is how would a helmet, if you say face mask gives you large side events and helmet is maybe a winner, how does helmet compare to heated high flow? The answer is we don't know, at least as we didn't in 2020, but by network analysis, and I kind of love this because you see, you've got a forest plot that looks real, that favors the helmet for both intubation and mortality, but we don't have any trials, right? Number of patients, 0, number of trials, 0, quality, low, do you think? But at least the helmet came out the winner compared to heated high flow using network meta-analysis. Now we do have, and there you go. But we do have one trial, and now again, it depends on what you think. I think COVID pneumonia was ARDS just like any other ARDS, and this was in JAMA 2 years ago. This was a head-to-head of heated high flow with helmet. Now you can say, well, it's all COVID. We need this in other population. Yeah, our ARDS population tends to be contaminated with things in our ARDS, but in this head-to-head comparison, no differences in mortality, length of stay, ventilator-free days. So more recently, there's more and more meta-analyses. The basic bottom line here, it says, when you compare heated high flow versus face mask, these things all decrease intubation. They probably don't decrease mortality. Most recent network meta-analysis, again, maybe there's a mortality benefit to helmet, but they all seem to decrease, whether it's helmet or face mask, non-invasive, or heated high flow. They all seem to decrease from intubation, and maybe not, at least in the one head-to-head it didn't, but helmet will decrease mortality. All right, so that's keeping the tube out. So we have 2 ways we look at these respiratory devices. One is keeping the tube out, and the other is keeping the tube out once you've taken the tube out. In other words, post-extubation support. So that is the other arena where these modalities are employed. And I'll tell you, I was actually on a technical expert panel for the Annals of Internal Medicine, did a guideline a few years ago, and I had to explain they needed to separate this literature into 2 because they were different questions. Anyway, so extubation. So let's think about this. Again, we had in the adult world non-invasive ventilation available since '89 in Maduri, and we've really been using the last 10 or so years heated high flow. So the questions were earlier being addressed by non-invasive ventilation. It's important to think that there's really 3 things here, right? One is I pulled the tube out and you're failing, but instead of sticking it back in, I'm going to put you on non-invasive. Okay, that's so what about post-extubation respiratory failure? The answer is no, just intubate. I'll show you that literature in just a second. Versus the number needed to treat phenomenon. In other words, I'm taking the tube out, and in a certain population, I'm immediately going to put you on non-invasive ventilation, whether you're looking good or no matter how you look. And the idea is in preventing a crump and a reintubation in some of these people. And we'll talk about this because it seems to work in high-risk population. That's fine. And then what about facilitating weaning? In other words, you failed to wean, but you're hypercapnic. Couldn't you just say, pull it out and put them on non-invasive? And there is actually a little bit of literature on this, but I wouldn't suggest you go there. All right, so this was a paper that's often forgotten. This was nice post-extubation respiratory failure. You've already failed. It didn't work. Guess what? In other words, your mission here with an extubation, a planned extubation or unplanned for that matter, isn't to wait until they're going down for the third time to stick a face mask on and think something good's going to happen. It's not going to happen. That patient needs to be intubated. When it comes to COPD, for the longest time, it was a little bit vague until this Lancet paper came out. Hypercapnic COPD, just like hypercapnic COPD on the front end of keeping a tube out, decreases the rate of intubation and ID mortality. So it's a win. What do the guidelines say? Well, here's what the guidelines said, 2017. They're getting a little old now. And in fact, the guidelines were just being put together at a time really that heated high flow literature had comparison literature was emerging, but it said, look, strong recommendation, moderate quality evidence, non-invasive ventilation for high-risk patients as variously defined in various studies. And so what are the risk factors for failing post-extubation non-invasive ventilation? Well, sicker people with pneumonia who are more tachycardic or tachypneic or hypoxemic or breathing rapidly or obese. I mean, it kind of makes sense, right? So on the one hand, you might want to use this in higher risk patients. On the other hand, got to use your head just as you do on the front end. Their patients are also not guaranteed to succeed. So there was an early signal that says, look, what about heated high flow? I mean, we've got this modality, and now in the adult world, we borrowed it from the pediatric world, and it was studied first in post-op patients and said, hey, you know what? Non-invasive is not any better, than heated high flow. Now, I'll tell you for a fact, respiratory therapists do not like to use non-invasive ventilation post-extubation. I mean, you just pull the tube out, you know the drill. You see people are kind of gagging a little bit, maybe a little, hoarse voice, and next thing you know, you're coming out with a mask. Okay, versus that wonderful little cannula under your nose. Well, we do have some non-cardiac, just other high risk. So again, depends on high risk. This was done in Spain, Esteban, and so this was comparing post-extubation, planned extubation, high risk patients. Now, what's high risk? Older, heart failure, COPD, body mass up, airway issues, comorbidities, prolonged ventilation, secretion problems. Yeah, I think that's an acceptable population to be called high risk. Heated high flow came out non-inferior, just as good as it. Now you could say, well, what about the hypercapnic COPD population? Well, they were blended in this larger population and not necessarily sufficient to tease out as an entity. I already showed you that Lancet paper that said that did benefit them. So is heated high flow non-inferior to non-invasive ventilation in post-extubation patients who have acute and chronic hypercapnic COPD? I don't think we necessarily know that. But all I know is if I try to be a little bit selective. If I have a really god-awful COPD patient, I will make a special pleading to my respiratory therapist to go to post-extubation, non-invasive over heated high flow. For heated high flow, they'll slap it on every time. Right, so those are the sick people. And so post-extubation support, considered hypercapnic, other high-risk patients, it's equivalent post-cardiac patients and in high-risk population, but we don't know about the COPD population. What about patients who aren't at high risk? Well, that was a parallel study. And this was actually a comparison of heated high flow versus just regular oxygen mask. And this one kind of rocks my world here a little bit because all that table I showed you, all those comorbidities, well, this is a patient population that lacked all those things. So you might think that heated high flow wouldn't matter. And in fact, it did. In 96 hours, the rate of reintubation was decreased to 4.9 over 12.2. And I can say that our ICU probably has about 10% 48 to 72 hour reintubation rate. Now, they get heated high flow for 24 hours. And what bothers me about this is, we're often willing to send people out after 12 hours post-extubation. So this would mandate you keep even like your simple drug overdose that wakes up, didn't aspirate, and gets immediately extubated in the ICU for a full 24 hours more heated high flow, unless you get them on the floor with this. So it's food for thought. Do I routinely give every extubation heated high flow on the basis of this? I don't know. I tend to think, in all honesty, that in Spain and perhaps in Europe, they're also a little more aggressive with extubation, but I don't know. All right. The latest wrinkle, however, if you like heated high flow and if you like non-invasive, you wait until you try both. And so in JAMA, just pre-pandemic population, you can see a 600 plus patient population of high-risk patients who then received both. They started off on non-invasive and they tried to keep that to 4 to 12 hours, but then also used 50 liters a minute of heated high flow. And that was the biggest winner, okay? And it was particularly a winner in hypercapnic patients, you might imagine, with that puff of air getting out of non-invasive compared to just heated high flow. But the reintubation rate of 7 days was decreased from 18 to 11%. No mortality difference again, so we don't tend to see mortality signal. So have we done it this way? I mean, I have a pretty hard time getting people on non-invasive post-extubation, particularly when we don't really have robust literature signaling out a superiority to heated high flow. But it you kind of get that hint over here, but we don't have it. So now we have a meta-analysis here, and as I just kind of told you in the studies themselves, pretty much either modality, in this case they're calling it NIPPV instead of NIV. Either modality is pretty good at reducing reintubation, but we don't really have a mortality benefit. So pick them what you want, but for our money, it tends to be easier to use non-invasive. I'm sorry, heated high flow than non-invasive. All right, so I think that's about it. So what have I told you? Well, keeping the tube out, non-invasive ventilation for cardiogenic pulmonary edema, acute chronic hypercapnic respiratory failure. In terms of acute hypoxemic respiratory failure, heated high flow is probably the winner, but the helmet might be even better. And the head-to-head, the only one we have is COVID and didn't make any difference. In the post population, both are good for preventing reintubation, in fact, like sicker patients, but probably no mortality benefit. And should be used at time extubation and not once you're already failing. So I think that's what I have for you. I can't really predict the future of where this is all going, and we've had a lot of studies that have brought us to this point. I'm not sure there's going to be a huge hue and cry to do many more large trials of this sort. But anyway, so I thought I'd finish with a cute New Yorker cartoon that kind of shows that life's unpredictable. So thank you for your time. I hope you enjoy your virtual day here visiting, and I'd be happy to answer any questions.